Welcome back to the Deep Dive. Today, we are tackling what is, and I don't think this is an overstatement, arguably the single most critical, highest stakes topic you will ever face: safeguarding.
Absolutely.
It sits right at the intersection of clinical care, the law, ethics, and it just completely dominates the professionalism part of the MSRA SJT.
It really does.
It's dense, it comes like all the time, and you have to make decisions that are not just fast and confident, but lawful. That's the key bit.
That is the key bit.
So our mission today really is to cut through all that complexity. You've got the GMC, the CARE Act, working together to safeguard children, and just give you some simple, actionable frameworks, the kind of mental checklist that fires instantly so you can score well and, more importantly, protect your patients.
Yeah, and I think that's the point. This really is the pinnacle of our professional duty. When the SJT or, a real-life scenario throws a safeguarding issue at you, it's testing more than just your knowledge. It's testing your judgment when you're under the highest possible stress. It's not just knowing that you should do something, but what's the precise legal mechanism? Who exactly do you call? And how do you handle that fundamental conflict between keeping a secret and your duty to protect? Success in these questions, it really hinges on two things. First, avoiding delay at all costs. And second, making sure every single piece of information you share is done securely and, like you said, with a justifiable legal basis. That robust process is what the exam rewards every single time.
Okay, let's just jump right in with a high-tension scenario, because these things never arrive neatly packaged, do they?
Never.
So imagine this. You're seeing a 14-year-old patient. They're in for something minor. And just as you're wrapping up, they lean in and quietly tell you that their teacher has been sending them inappropriate messages online.
Oh, wow.
They're visibly shaking, they look terrified, and they look you right in the eye and beg you, please, promise me you won't tell anyone, or I'll be in serious trouble. I'll never trust a doctor again. What do you do in the next 60 seconds? The conflict is just immediate. It's visceral. It's that commitment to confidentiality, the thing that builds trust, versus your mandated duty to protect a child from abuse, especially from someone in a position of trust. That 60-second decision, it determines everything.
Yeah, okay. So if you remember one thing, and one thing only from this whole deep dive, let it be this. The core truth for safeguarding is this: act immediately on a reasonable suspicion to protect the vulnerable person. Share the minimum necessary information lawfully and securely with the right agency, and document every single step objectively using facts and verbatim quotes.
That feels like the anchor for everything else we're going to talk about.
It is.
So let's talk about why this is such a huge deal in the SJT.
Yeah.
The GMC duties are just so clear on this, aren't they?
Yeah.
It directly tests your duty to protect children, your duty to act on concerns, and this is the one that causes the most stress. Your responsibility to disclose information for safety, even when they beg you not to.
And that last point is so critical for the exam. The scoring is just so heavily weighted towards actions that show early protection and using the robust statutory process.
What do you mean by statutory process?
I mean activating the legal pathways. Calling children's social care, or MSH, contacting adult social care for a Section 42 inquiry, using things like MARAC for high-risk domestic abuse.
So not just dealing with it yourself.
Never. If you hesitate, if you try to manage it alone, or if you choose that classic trap of watchful waiting or just giving a leaflet in a high-risk situation, you will not meet the standard of a safe doctor. And remember, these decisions, they prevent two kinds of harm. There's the immediate serious harm like abuse or, God forbid, non-fatal strangulation. And then there's the cumulative harm, the slow, grinding effect of neglect. Delay in this context is professionally indefensible.
So what you're saying is we're not looking for the most empathetic answer in isolation. We're looking for the legally and professionally required action, even when it feels really uncomfortable.
Exactly. Safety and legality always have to come before our own comfort.
Okay, so let's get into those core principles, the anchors of action. You said we need to pull from the GMC, the CARE Act, and working together to safeguard children.
Yep, those are the three pillars.
Let's start with the GMC mandate. You said we have to act on suspicion, not certainty. Why is that distinction so important in practice?
It's a fundamental protective principle. You must intervene early when you have a reasonable cause to suspect significant harm. Think about it. Clinically, you are often the very first, maybe the only professional to see or hear the signs.
Right.
If the GMC said you had to wait for proof, the victim would just be left in a dangerous, often escalating situation while an investigation stalls. So safeguarding is entirely risk-based.
So what's the threshold for reasonable cause?
It's simple, really.
Yeah.
If you have enough information that a reasonable colleague hearing the same story would share your suspicion, then you have to act. Protection has to come before proof. That's the mindset that scores highly because it completely eliminates that wait-and-see trap.
And that leads straight into the biggest anxiety for junior doctors.
Yeah.
Sharing information. Lawful information sharing. If I'm overriding confidentiality, how do I not get it wrong?
You have to see it as your professional safety net, as long as you stick to the rules of proportionality. You are allowed, in fact, you are required, to disclose information to protect people from serious harm. And this is the key bit. Consent is not required to share for safeguarding purposes when it's necessary to prevent that harm.
That's a huge override.
It's a fundamental override. But, and this is a big but, it's not a free pass to overshare. Your process has to be disciplined. You share the minimum necessary information, only what the receiving agency, like MARAC or MARA, needs to start their job, and you use secure channels, NHS email, official referral forms.
Not WhatsApp.
Never WhatsApp. And then you document everything. You write down what you shared, who you shared it with, and why you had to, what your legal basis was for overriding that confidentiality.
That minimum necessary point is so important. It's not about sending the entire medical record.
Absolutely not. The best SJT answer is share your thinking about both protection and legal governance. It's a balancing act.
Okay, let's move to the actual legal frameworks, starting with child safeguarding. Children Act 1989, Working Together 2023. What are the referral thresholds we need to have burned into our brains?
For children, it's pretty clear. Your referral goes to children's social care, usually through something called the Multi-Agency Safeguarding Hub, or MAH, and you're looking for two main thresholds, Section 47 and Section 17.
S47 and S17.
Right. Section 47 is the high bar. It means you have reasonable cause to suspect significant harm. This triggers a mandatory child protection inquiry. We're talking non-accidental injury, severe neglect, sexual abuse, or that classic red flag. Any bruising in a pre-mobile infant.
And Section 17.
Section 17 is for a child in need. This is where support is needed to help their health or development. This often covers that cumulative harm we talked about.
Like what?
Chronic low school attendance, persistent poor hygiene, failure to thrive that you suspect is down to neglect, family substance misuse that's affecting the child's life. The safe doctor knows that a Section 17 issue, if you ignore it, can very quickly become a Section 47 emergency. The default position is always child-centered protection. Assume the risk is higher than you think.
So it sounds like the key is deciding if the child's needs can be met with support, that's S17, or if a formal protection investigation is legally required, which is S47.
Precisely. And in the SJT, if there is any doubt at all, any ambiguity in a high-stakes scenario, you always choose the action that leads to the most thorough assessment. That means leaning towards the S47 pathway if significant harm is even a reasonable suspicion.
Okay, that makes sense. Let's switch to adult safeguarding. The CARE Act 2014, Section 42. This feels more complicated because you've got this tension between protecting someone and their right to make their own choices.
It is more complex, no doubt, because we're dealing with liberty and personal choice. A Section 42 inquiry gets triggered by adult social care when a person is 18 or over, has care and support needs, is at risk of abuse or neglect, and this is the crucial part, is unable to protect themselves because of those needs.
So if they have capacity and can protect themselves, S42 might not apply.
Often it doesn't, though you might still have a wider public duty to share information if other people are at risk from their situation.
And how do we navigate this ethically? We always hear about the 6 principles.
The 6 principles from the CARE Act are your ethical roadmap. They're actually quite intuitive. You've got empowerment, which is all about supporting people to make their own decisions. Then prevention, acting before harm happens. Proportionality, using the least intrusive response for the risk.
Okay.
Then protection, which is support for those in greatest need. Partnership, working with other agencies. And finally, accountability, making sure everyone is clear about their roles.
That first one, empowerment, that ties directly into something called making safeguarding personal, or MSP. The SJT loves testing this. What does it actually mean in the clinic room?
MSP is basically the philosophy behind modern adult safeguarding. It means shifting the focus from just, ticking boxes and filling out a form to the actual outcomes that the person wants.
So you have to ask them.
You have to ask them. The golden question is, what does safe mean to you? You have to actively find out what they want to happen. The challenge, of course, is when what they want clashes with your professional judgment of the risk.
Right.
If the adult has capacity and chooses a risky lifestyle, say self-neglect, hoarding, but they're refusing all help, Your duty generally leans towards respecting that choice, as long as they aren't harming anyone else. But you have to rigorously document that capacity assessment and their reasons. If capacity is gone, then you have to act in their best interests, using the least restrictive option. That's the nuance the SJT will test. Respecting autonomy unless capacity is absent or there's an overwhelming public safety risk.
Okay, this is brilliant. So let's translate all this legal and ethical duty into a single, unified framework, a sequence you can just deploy instantly. We're calling it the safest doctor's pathway, 5 steps.
Yes. And this framework applies to everything. A child disclosure, a high-risk domestic abuse case, adult neglect. It keeps you safe, keeps the patient safe, and makes sure the process is robust.
Okay, step 1. Check immediate safety and treat. This feels like the ABCDE of safeguarding.
Exactly. It's the clinical emergency stage. You stabilize the immediate risk. If there are injuries, you treat them. If there's imminent danger, ongoing violence, a threat to kill, a weapon mentioned, or critically non-fatal strangulation, you have to think about calling 999 immediately.
Non-fatal strangulation, you've mentioned that a few times. Why is that such a critical red flag?
Because it's one of the biggest predictors of future homicide. And clinically, it can cause delayed catastrophic injury. In the SJT, recognizing NFS as an immediate medical and criminal emergency, even if the patient looks okay, is a huge high-scoring marker. You stabilize the acute threat first, always.
Okay, threat stabilized. What's next?
Step 2, see alone and assess. Once the immediate danger is managed, you need privacy. You have to see the person alone, away from anyone who might be coercing them.
Mm-hmm.
For a child, you have to be upfront about confidentiality. You use that model phrase. I hear what you're saying, but because I'm worried about your safety, I can't promise to keep this a secret. I have to get help to keep you safe.
And for an adult?
For an adult, this is where you apply MSP, ask them what they want, and if it's relevant, you do a focused capacity assessment. And for any domestic abuse disclosure, you go beyond just listening. You must complete a proportionate DSH risk assessment to actually quantify the level of risk. That assessment forms the basis of your referral.
So privacy ensures an honest story, and the assessment gives you the data for the next step. It flows.
It does. Which brings us to step 3, consult and refer promptly. No exceptions here. No, let's see how things are tomorrow. The high-scoring move is immediate escalation. First, tell your clinical senior and your organization's safeguarding lead straight away. Second, make a same-day referral. For a child, that's to MASH or Children's Social Care, quoting S17 or S47. For an adult, you consult with or refer to Adult Social Care about a potential S42 inquiry. And if it's about a staff member, it's a special referral to the LADO.
We'll come back to the LAD.
Yes. The point is, promptness is rewarded. Getting advice from the statutory agency is always safer than relying on your own judgment.
Okay, you've made the referral. Step 4.
Step 4, share lawfully and minimally. This is all about the governance of how you communicate. You only share the minimum necessary information for the safeguarding agency to do their job. And you have to use secure channels, NHS secure email, official portals, not your personal phone.
And document it.
And document it. 3 things. What you shared, with whom, and why, your legal basis. This creates your audit trail and proves you've followed data protection rules.
And the final step. Step 5. Document objectively and plan. Why does the SJT care so much about how we write the note?
Because the note is the legal record. It has to be defensible. Objectivity is everything. You must record verbatim quotes from the patient, in quotation marks, that's direct evidence, chart injuries on body maps. And critically, your note must clearly separate fact, patient states, from your professional opinion. Impression is.
And the plan.
Your note has to end with a clear multi-agency plan. Did you refer to an independent domestic abuse advocate, an IDVA? Was a referral made to MARAC? Who is following up and when? A high-quality record is just indispensable.
Those 5 steps are excellent, but, under exam pressure, you need mental shortcuts. Let's talk memory aids.
Absolutely. Mnemonics are how you recall this stuff instantly when your heart is pounding.
So for adult safeguarding, we have the 6 principles.
Right. We talked about them. Empowerment, prevention, proportionality, protection, partnership, and accountability. I think of it as EP4PA. Just remember, empowerment, listening to what the patient wants, is so often the decider in adult cases where they have capacity.
Okay, and for domestic abuse?
For DA, we use Safe Home. It maps directly onto the actions you need to take.
Go on.
Screen privately. Acknowledge and validate what they've told you. Flag children because they are always affected. Evaluate risk with the DSH tool. Help plan for their safety. Offer options like an IDVA or the police. MAC if the risk is high. And Evidence record everything.
Safe home. I like that. It's really practical. And you had one for the referral itself.
Yes, for the crucial referral route, the different legal doors you have to go through. Remember, DORS.
Okay.
Determine the correct forum. Is it MASH, LADO, MARAC? Obtain senior support. Offer or withhold consent safely, explaining the limits of confidentiality. Refer with the right tools, like the D-H score, and summarize your actions clearly in the records.
I really like that R for refer with tools. You don't just send an email, you send the evidence that dictates their response.
Precisely. And just one more thing. For a visual cue, when you read a safeguarding scenario, just picture a big, bright red warning light flashing over a body map. That red light means two things must happen at once: immediate documented escalation and activating the correct statutory referral pathway, even if it means overriding confidentiality. You cannot proceed alone.
Right. Let's apply this. Let's look at the 4 scenarios the SJT will throw at you again and again.
Yes, recognizing the pattern is half the battle. It lets you cut through the noise and get straight to the high-scoring actions.
Okay, pattern number 1. Bruising in a pre-mobile infant. A textbook red flag.
It is. A baby that cannot crawl or walk should not have bruises. The stats are tiny, less than 1%, and the correlation with non-accidental injury is terrifyingly high.
So what's really being tested here is not just spotting the bruise.
No. It's testing your immediate recognition of massive red flag, your understanding that this automatically meets the Section 47 significant harm threshold, and your ability to prioritize a specialist assessment. It's a life or death decision point.
So best action.
It's twofold and immediate. Arrange an urgent specialist pediatric assessment because they are the experts in telling accidental from non-accidental injuries. And at the same time, make a same-day referral to Mass Children's Social Care for a mandatory Section 47 child protection inquiry.
And the traps. Where do people go wrong?
Delay. Pure and simple. Waiting till the next day. Accepting a vague story from a parent like, oh, he must have hit himself on the toy bar. Or assuming it's accidental without a specialist opinion. Any delay puts that child back into a potentially lethal environment. You must act on suspicion.
Okay. Pattern 2. An allegation against a staff member or a volunteer. This is where we hear about the LADO. Why is this different?
It's a completely different pathway. What's being tested is your knowledge of the LADO process. You need to recognize that an allegation against someone in a position of trust, a doctor, a teacher, needs an impartial, time-critical investigation that's separate from the usual MSH pathway, which tends to focus on family risk.
So who is the LADO?
The local authority designated officer, they manage these specific allegations.
Best action.
Immediate internal escalation to your senior, your safeguarding lead, followed by notifying the LADO within 1 working day. That notification is just the facts, no speculation, and you preserve any evidence. The LADO then decides if that person is a risk to children and manages the whole investigation.
So the LAO looks at the professional risk, MESH looks at the family risk.
Exactly. And the low-scoring traps here are trying to handle it yourself. Contacting the accused person to get their side of the story, for example.
Oh, definitely don't do that.
Never. Or referring it through the general MIS inbox. Both of those actions bypass the specialist's LADO duty and could completely compromise an investigation.
Okay, pattern 3. High-risk domestic abuse. You've mentioned non-fatal strangulation.
This is incredibly high stakes. NFS is a massive indicator of immediate severe risk. Clinically, it's an emergency. Socially, it's a huge predictor of future homicide.
So what's being tested?
Recognizing those high-risk markers, using the -H risk assessment tool, and activating that multi-agency response, MARAC.
What's the best action, step by step?
Urgent clinical assessment for injury. Complete the -H assessment. If the score is high, usually 14 plus, or just your professional gut feeling says this is high risk, you must refer to MARAC and get the victim access to an IDVA. And crucially, if the risk is that high, you share the minimum necessary info with police or MARAC without consent. Your duty to protect is paramount.
Can you just clarify MARAC for us?
Yeah.
MASH is a hub. What's MARAC?
ASH is the front door for referrals. MARAC is a meeting, a high-level conference where all the agencies, police, social services, health, housing, get together to discuss the highest-risk DA cases and make a coordinated safety plan. When you refer to MARAC, you're asking for a full multi-agency wraparound response.
And the low-scoring decoys here.
Anything that minimizes the risk, offering couples counseling, dangerous, advising the patient to talk to their partner, even more dangerous, and just giving a leaflet and discharging, that's a complete failure of your professional duty to activate the high-risk safety plan.
Okay, last one. Pattern 4. Adult self-neglect, hoarding, fire risk. This is the most ethically tricky one, isn't it?
It is, because that conflict between autonomy and safety is right in your face.
What's being tested?
Your ability to balance making safeguarding personal MSP against that Section 42 duty to inquire, and your ability to rigorously assess capacity.
So best action.
First, MSP. You talk to the person, you document what they want. What does safe mean to you? Second, you do a focused capacity assessment on the specific decision at hand, like their ability to manage fire risk. Third, proportionate multi-agency referrals. If there's a life safety hazard, you have to contact the fire service, housing, and consult with adult social care for an S42 inquiry.
But what if the person has capacity, but their hoarding is a massive fire risk to the whole building? Do I still have to just respect their wishes?
Not entirely, and this is the nuance. If the risk is overwhelming and affects public safety, the public interest override, you have a duty to share that information with the fire service, regardless of consent. But you must avoid being coercive. You're acting on public safety, not just their personal welfare.
And the traps.
Forcibly intervening or just assuming they lack capacity without assessing it, that fails MSP and scores very poorly. But doing nothing at all is also wrong because you're ignoring a clear safety hazard.
This is so useful. Understanding the traps is just as important as knowing the right answer. Let's just list them out. What's the number one trap?
Wait for proof before referring. This is the biggest scoring error. It breaches your duty to act on reasonable suspicion. Safeguarding is about risk, not certainty. Delay is dangerous.
Trap 2.
Promise to keep it secret. This completely misstates the law. Your duty to protect from serious harm overrides confidentiality. The highest scoring action is to explain the limits of confidentiality, not promise absolute secrecy.
What about discuss everything in the staff WhatsApp group to get opinions?
A huge information governance breach. It's insecure and it's not proportionate. You share the minimum necessary information via secure official channels. That's it.
The passive approach. Only give a leaflet and discharge.
That fails your professional duty to escalate and use the statutory safety net. In a high-risk situation, a leaflet is just not enough. You have to use the official pathways.
What about how you ask questions? The trap of asking detailed, probing, or leading questions.
Your job is to record the disclosure and treat injuries. Forensic interviewing contaminates evidence, and it's not your role. That's for specially trained police or social workers. You record what was said, not lead how it was said.
And with adults, ignoring their wishes and intervening coercively?
That fails MSP. Unless capacity is formally assessed as lacking or there's that overwhelming public safety risk, you have to respect their autonomy. Coercion is an absolute last resort, only used in a documented best interests decision.
Last one. Attempting to mediate or involve the family in the initial chat.
This is just incredibly dangerous. It exposes the patient to more coercion and harm. Step 2 is always see alone and assess. Always.
Okay, let's nail this down. Rapid fire examples. If X happens, you do Y.
Let's go.
If a child discloses abuse and begs for secrecy.
Then you explain the limits of confidentiality immediately and make a same-day referral to NHS.
If you see signs of cumulative neglect, failure to thrive, missed appointments.
Then you build a clear chronology in the notes and make a prompt S.1 civ or S.47 referral.
If a patient discloses escalating domestic abuse and mentions non-fatal strangulation,
then you complete a DSH assessment immediately. Refer to NHS because it's high risk, and consider involving the police.
If an adult with care needs is being financially abused by a relative and can't protect themselves,
then you refer to adult social care for a Section 42 inquiry, making sure you've documented MSP and capacity.
And finally, if the concern is about a hospital staff member,
then you tell your consultant immediately and you notify the LADO within 1 working day.
Perfect. So if we had to boil this entire massive topic down to 3 key takeaways for the exam, what would they be?
Okay, 3 absolute truths to carry with you.
1.
1. Always act on suspicion and escalate early. Delay is the single biggest scoring error. You act on risk, not on proof. 2. Use the correct door. MASH for kids, a LADO for staff, MARAC for high-risk DA, and a Section 42 consultation for adults. Using the right pathway for the specific risk is key.
And 3.
3. Lawful information sharing means sharing the minimum necessary for safety, using secure channels, and always recording your reason for sharing, especially if you're overriding consent.
You now have the structure. You have the 5 steps, the mnemonics, the major scenario patterns,
Huh.
everything you need to make those rapid, confident, and legally sound decisions when the stakes are at their absolute highest.
And these frameworks, they really do provide the foundation for safe and defensible practice. Just remember, prioritizing protection, using the correct legal pathway, and documenting every step you take, that is the hallmark of a professional doctor. And keep practicing your decision-making. Using resources that really reflect these frameworks, like those on pastmsra.com, is invaluable.
That brings us to the end of this very comprehensive deep dive. We've really covered the entire spectrum of UK safeguarding, from those critical red flags in infants all the way to the complexities of adult self-neglect.
And knowing the structure, knowing why you call the LADO instead of MASH, or what the difference between MATCH, MARAC actually is, that ensures your practice isn't just compliant, it's genuinely safe. And that confidence, which comes from real knowledge, is what matters most.
Join us next time for another deep dive into high-yield professionalism topics.